standardization. We'll talk in standardization about AVR versus lead 1 and lead AVL, and we'll talk about artifact and velocity and voltage. Each electricity or each electric waves has direction like AVR versus 1 and AVL, and has a velocity and has voltage and also has artifact. First, we can speak about AVR versus lead 1 and lead AVL. If we look to lead AVR here, AVR looked downward and lead 1 and AVL looked upward, or in another explanation, in AVR there's a prominent Q wave, and lead 1 and lead AVL a prominent R wave. This is standardized ECG. If we can't find this picture or reversal of leads in limb leads, especially lead 1 and AVL and lead AVR reversal, we must look on the R progression in chest leads. In R progression in the chest leads, R starts as a small wave from V1 and gradually enlarged or gradually growing till the end of V6. R in V, so R in V6 is maximal voltage, and R in V1 is minimal voltage, and also S wave in V1 is maximal voltage, and S wave in V6 is minimal voltage. I will give an explanation here by the dashboard. If we look in lead 1 and lead AVR and lead AVR and lead AVL, AVR looked downward and lead 1 looked onward and lead AVL looked upward. If we see the reversal of these leads in lead 1 downward and lead AVL downward and lead AVR upward, here we look to V1 to V6. If you find normal progression of R wave progression from lead V1 to lead V6, so here is a technical error for ECG. But if we found abnormal R wave progression, or what is called mirror image with zoom in V1, here we found in V1 and V2 and V3 and V4 and V5 and V6. It is called mirror image with zooming in V1, like the large brother and the small brothers. This is diagnosed of dextrocardia. In this ECG, we look at reversal of limb bleeds, and we found in V1, V2, V3, and V4, and V5, and V6 normal RA progression or good RA progression. So it's a technical error. Here we found two ECGs. We will look to the technical error of the right ECG. Here is a reversal of limb bleeds in AVR and lead 1 and AVL in both ECGs, but the difference that in our wave progression in chest leads in the right side on the right ECG there is normal R regression or good R regression, so it's a technical error. But in the left ECG there is zooming image or a mirror image with zooming at V1, so it is tachycardia. Now we talk about artifacts. In artifacts, we different from some types of artifacts like baseline wonder. In baseline wonder, I can move on the line of baseline by a pin, and the second or number B power line interference. In power line interference like telephone or like wires or like monitor. This is the causes of power line interference. In muscle interference, like in case of Parkinsonism, muscle interference, differential diagnosis with atrial fibrillation. But in atrial fibrillation, we look in RR interval. There is a regular RR interval in atrial fibrillation, but in muscle interference, regular RR interval, like here. And number D, in number D, loose electrodes like a patient or like a dead man while doing CPR. This picture of CPR man or loose electrodes. The next slide, velocity. In case of velocity, we know that standardized velocity like 25 millimeters. In this ECG, the velocity here in this paper 25 millimeters, and the ECG or the QRSS or RR interval here by look is a tachycardia, and by look it is narrow complex, so regular narrow complex tachycardia. In this patient, we see QRS and a wave in between, mostly T wave. It is T wave also, but if we want to see P wave here, we can change the velocity from 25 millimeter to 50 millimeters, like here. In this ECG, we change the velocity of the main or of the same patient from 25 millimeters to 50 millimeters here. And here we can find B wave. This is B wave. It is a complex, and T wave and B wave. The next slide, the 36-year-old female patient come with palpitation. The heart rate, her heart rate was 270 beats per minute. This ECG is now complex tachycardia alternating with white complex tachycardia of some sort. After change the velocity from 25 millimeters of ECG to 50 millimeters per second, we look here the QRS or complex and the same shape of T wave, no B. And here also it's a same shape of T wave and no B. It is atrial fibrillation, irregular atrial fibrillation alternating with non-sustained ventricular tachycardia, white complex tachycardia with no P wave, and regular non-sustained ventricular tachycardia. So irregular waves alternating with regular waves in this ECG of the female patient, 36 years old. Here we can speak about voltage. In voltage, just give a look to low voltage and predominant voltage or high voltage. In low voltage, the specific definition of voltage is that any limb lead voltage must be less than 1 large square. Less than 1 large square. It's a specific definition in limb leads, but specific definition in chest leads is any chest leads less than 2 large squares. But the specific definition sometimes not enough to diagnosis, because some leads may put it in edematous part or localized edema of the chest or the localized edema of the hand or feet or lower limb edema or. So there is a sensitive definition. In sensitive definition, lead 1 plus lead 2 plus lead 3, summation of voltages of these leads must be less than 3 large squares, and summation of voltage of lead V1 and lead V2 and lead V3 must be less than 3 must be less than 6 large squares. It's a sensitive definition. In the predominant voltage diagnostic and the prognostic. A predominant voltage diagnostic, we will see the diagnosis of left ventricular hypertrophy, we'll see the diagnosis of HOCM, we will see the diagnosis of amyloidosis in the predominant voltage. And prognostic, in the predominant voltage, we will give a prognostic sign to cardiomyopathic patient by use of a predominant voltage. We can start now in causes of low voltage QRS fat or air or fluid. Any fat or air or fluid can alternating with electricity movement or electricity voltage. And myocardium infiltrates like amyloidosis, and also loss of viable myocardium like post-MI of dilated cardiomyopathy. So we'll start from outward to inside. Any obesity, any myxedema, any pleural effusion, any pneumothorax, any COPD, any pericardial effusion, any constrictive pericarditis, any myocarditis, any pericardial pneumopericardium, any pneumomediastinum, any post-MI, and any dilated cardiomyopathy, and also any amyloidosis. All of these are causes of low voltage QRSs. In this ECG, we'll see low voltage QRS by both sensitive definitions and specific definition in both limb and chest leads. And in echo, we find in echo left ventricular hypertrophy here. So low voltage in ECG and left ventricular hypertrophy in echo, it's a diagnostic for cardiac amyloidosis. Okay, but mostly most important to see low voltage in both limb and chest leads here to diagnose amyloidosis. It's a 70-year-old man comes with dyspnea. Here, both ECG, the first ECG low voltage in limb leads, and not low voltage or prominent voltage in chest leads, but in the second ECG, low voltage in both limb and chest leads. Here, the prognosis, the man is end-stage cardiomyopathy in the first ECG, not in the second ECG. So here, the prominent R wave or the prominent voltage here in the first ECG is a prognostic in dilated cardiomyopathy. Here we can see low voltage in limb leads and low voltage in chest leads with tachycardia. It's 150%, 150 beats per minute, and also alternating electricity or electrical alternatives. In electrical alternatives, must be the difference between the beat and the other beat at least 1 large square. So it's pericardial tamponade, severe pericardial effusion or pericardial tamponade, and the severity of pericardial effusion depending on the alternative electricity. Here we can see two ECGs. The right ECG, we can see here abnormal. It's prominent voltage of S wave in V1 and the prominent voltage of R wave in V6. Here we can count the large squares 1, 2, 3, 4, 5, and 6, 7, 8, 9. So the summation of both voltages of S in V1 and R in V6 are 9. If the summation of these voltages more than 7 large square, it's diagnostic for left ventricular hypertrophy. But stop, we talk about amyloidosis and say that in amyloidosis, low voltage ECG with LVH in echo. So what is the difference? Here is the difference. The exception of case of diagnosis of LVH by echo, unless diagnosis of LVH by ECG here in amyloidosis. Okay. The next ECG, there is a high voltage or the predominant voltage of S1 of S in V1 and the predominant voltage of R in V6. R in V6 and S in V1, 1, 2, 3, 4, 5, 6 large squares, 7, 8, 9 large squares. So if the summation of voltages of S wave in V1 and R wave in V6 more than 7 large squares plus deep inverted T wave plus ACT segment depression, it is diagnostic of HOCM in ECG. HOCM is associated with young death.
Please, can you repeat HOCM? Excuse me, doctor.
Yes, HOCM associated with younger mortality. High younger mortality.
What was criteria?
Criteria about criteria in ECG ECG. Dominant S wave in V1, S wave in V1, and R wave in V6. Just count the large squares of S wave in V1. 1, 2, 3. Sorry, 1, 2, 1, 2, 3, 4, 5, 6, 7, 9. It is a 9 large squares plus deep inverted T in V3. Look to inverted in lead V3, deep inverted T, and lead V4 and lead V5 and lead V6. And ST segment depression in lead 2. Here, 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 and here.
What about the total criteria of
T wave inversion, T wave inversion, SCT depression, S in V1 plus R in V6 more than 7 large squares. Okay, by vertical count. Understand?
Okay.
Okay. Diagnostic for HOCM. Here, 55 years old female patient presented with central crushing chest pain. What is your diagnosis here? SCT segment elevation in lead 1 and lead V2 and lead 2 and lead 3 and lead AVF, and also ACT. So okay, it is acute MI, acute ischemia. And also there is another diagnosis here. Look to the AVR and lead 1 and lead AVL. It is a reversal of leads, lead 1 and lead AVR and lead AVL. Lead AVR positive and lead 1 negative and lead AVL negative. Here. AVR versus lead 1 and lead AVL. Okay, so we can look to V1 from V1 to V6 in R wave progression. If there is a good or normal R wave progression, it is a technical error. If no R wave progression, but only mirror image with zooming at V1, it is a dextrocardia. So in V1, we can see RS, V2 RS, V3 RS, V4 RS, V5 RS, and V6 RS from the large to the smallest. It is zooming at V1 with mirror image from V1 to V6, so it's a dextrocardia. So this patient have 55 years old female patient, have acute ischemia and dextrocardia. Thank you.